Welcome to Cornea Care. Systemic associations of eye disease have always fascinated me. So I am happy to share with you joints and eye in this episode. Our only interest is to share cornea-related knowledge with general practitioner. A young girl of 17 years presented with complaints of sudden onset of bilateral redness and watering, which started 5 days ago. This was accompanied by gradual visual loss. She denied any trauma or foreign body fall. On examination, right eye vision was 3/60. Intraocular pressure was normal digitally. There was mild conjunctival congestion. Cornea had a central triangular epithelial defect with multiple infiltrates. All these were anterior stromal infiltrates, scattered in the central 1/3. One infiltrate was linear along the edge of defect and rest were patchy and without overlying defects. Other eye vision was 6/36. Again, there was mild conjunctival congestion but multiple anterior stromal infiltrates. Most of these had overlying epithelial defects in the form of erosions. Infiltrates were nummular, scattered in a circular pattern. Rest of the anterior segment was normal in both eyes. So I had a young girl with sudden onset of bilateral multiple infiltrates. What can be the cause? First decision in the diagnostic algorithm is to determine whether the lesion is infectious or immune in origin. Infiltrates in this case were whitish, non-suppurative, unlike the dense yellow infiltrates of infection, which went more in favor of immune. Secondly, bilateral infection is usually seen after trauma, contact with contaminated water, dirty contact lenses, or indigenous medicines. Rarely, hematogenous spread can also cause it. But in our patient, all these were absent. Bilateral immunokeratitis can happen in local ocular causes as seen in marginal keratitis or ocular rosacea, as we have discussed earlier, or it can be seen in many systemic diseases. Though rare, but bilateral HSK can also happen. So we started to rule out these. Her lid margins and rest of adnexa were normal, so local ocular causes were ruled out. Bilateral HSK is usually seen in patients with atopy or history of previous episodes, or they erupt with fever. She denied all these. Now we started asking about systemic organ systems. She told us that a month ago she had a bout of vomiting and diarrhea which lasted for 2 to 3 days only. But 2 weeks later she had marked swelling in her right knee and she was barely able to walk. They had taken an orthopedic opinion and now she was much better and the swelling was less. But as we can see, still there was some swelling visible. Orthopedician had given painkillers and oral NSAIDs and advised some blood tests for knee swelling. Her ESR and CRP were raised, rest of the tests were okay. RA was negative. He suspected it to be tubercular and Montaux was done, but it was negative, and in the meantime she had responded to oral NSAIDs only. Now I was able to solve this jigsaw riddle. Her GI symptoms followed by joint involvement and then ocular involvement in a sequence was fitting into diagnosis of reactive arthritis, which was earlier known as Ritter syndrome. In classic Ritters, there is a triad of urethritis, arthritis and conjunctivitis. Nowadays, medical literature prefers the term reactive arthritis over Ritter syndrome. In reactive arthritis, as the name suggests, the joints react to a primary infection at a different site. It is the result of an aberrant autoimmune reaction. Usually there is a gap of 2 to 4 weeks between these. Extraocular manifestations are very common. Urogenital infection is the most common trigger, which is usually due to chlamydia. Next is gut infection by some gram-negative bacteria, and very rarely respiratory infection can be the trigger. In joints, usually asymmetrical involvement of few leg joints is seen, but it can involve other joints too. In extra-articular manifestations, skin, eye, nails, tendons, ligaments are involved, though the list is very long. Main thing to understand is that all these systemic involvements are not by actual microbial invasion, rather it is the immune-mediated reaction due to some antigenic similarity between the microbe causing primary infection and the rest of the tissues. HLA-B27 positive people are more prone to it. In eye, most commonly conjunctivitis, episcleritis and uveitis are seen. Corneal involvement is seen in around 4% of cases. In fact, I had seen a patient in 2004 too, so it helped me in diagnosing this. Since we don't see these patients frequently, she was referred to a physician who agreed with our diagnosis. Since disease is immune, it needs steroids and antibiotic is just given for prophylaxis. She was started on loteprednol, moxifloxacin combination in 4 times dose. Very next day, her right eye peripheral infiltrates were less, but central infiltrate appeared more dense. This kind of phenomena is seen many times in infiltrates when the lesions are organizing. But the healing of epithelial defects tells us that we are on the right path and need not to alter any medication. Other eye was also better. In 5 days, infiltrates resolved completely and steroids were tapered quickly. In 4 weeks, corneas appeared absolutely clear. This is the picture of case seen in 2004. I hope this video helps you in diagnosing these kind of cases. Thanks for sparing your valuable time.